Members, it's appointed time and we have a quorum. I call a meeting to order. Agenda item number 1, information paper issued since the last meeting. The Secretariat has not received any information paper since the last meeting. Agenda item number 2, items for discussion at the next meeting. The next meeting will be held at 10:45 a.m. on the 12th of July. That is a Friday. We will be discussing elderly healthcare voucher, Greater Bay Area pilot scheme, and development of Chinese medicine. Any comment regarding these 2 items? If not, I'll ask the government representatives to enter the conference room. If I may remind members that the panel will be visiting 2 Grade 3 general hospitals in the Greater Bay Area on the 22nd of June for a duty visit. There are 13 members who have signed up for the duty visit. The Secretariat will inform members of the duty visit about the detailed arrangement. Any questions regarding our duty visit on the 22nd? If not, we move on to item 3, latest situation and response measures for seasonal influenza. The Secretary and his team are already here. When they are ready, they will walk us through the paper. As always, please only press the button to speak after the Secretary has finished with his presentation. Please also note the submissions from groups and individuals. Thank you, Chair and members. Since January this year, Hong Kong has entered the influenza season, which has gone on for 5 months until now. In June, we're still in the winter influenza season. The government is paying attention to it. We protect the vulnerable group and we try to meet the service demand. And to do this, we implemented a series of measures. And we've been reminding members that they should be prepared for the season. This CHP in January and April organized a press conference to talk about the prevention mechanism and measures. And in February, the Hospital Authority also organized a press conference on the measures adopted by public hospitals to deal with the influenza season. And in last October, the Health Bureau reported to the panel on preparatory work. Here, we are reporting on the latest situation of seasonal influenza. Prevention is always better than cure. Since September last year, we have been subsidizing public and private hospitals and providing vaccinations to people. In 2023-24, we administered 1.85 million doses of seasonal influenza vaccination, which is 20% higher than the 2022-23 period, which is a record high. The DHC's district health centers and the 18 districts and private organizations actually organized 210 vaccination sessions to provide education and injections to people. Viruses of influenza changes all the time, and that is why we have to update the vaccines each and every year. In February and March every year, the WHO would announce the proposed strains for influenza vaccines to be used in the Northern Hemisphere, preparing for the influenza season starting at the end of the year. After announcement of the strain recommendation, the manufacturers can start preparing for the production of vaccines for arranging the vaccination in the region in the Northern Hemisphere at the end of the year, so that the vaccines can be administered at the middle of the year. Usually in October, the government will start our seasonal influenza vaccination programs, and the programs will end around June, August the next year upon the expiry of the vaccines. So one very important thing is that the public should receive vaccination in October, and it is the most ideal timing for receiving the vaccination. They should receive it as soon as possible. they will enjoy the protection of the vaccination if they received injection in October. There is a change in the strains of influenza this year. It's changed from influenza A to influenza AH1. That is why the influenza season lasted 6 years from January to, or 6 months from January to June. So prior to the expiry of the vaccination, the general members of the public should receive a vaccination. Even if you receive the injection now, because the strains will change, the members of the public should receive another fresh vaccination in October in order to be protected in the next influenza season. There are people who suggest that we should increase the use of nasal live attenuated influenza vaccines LAIV among children. Actually, the CHP conducts outreach program at schools for SIVs. CHP send their staff to administer vaccination, and there are also subvented private organizations who conduct SIV programs in schools. In February and March every year, the CHP conducts a study to inquire about schools' willingness to participate in the coming school outreach program and the types of vaccines they would choose before vaccines procurement. According to the findings in the latest survey in 2023, only 26% of kindergartens and childcare centers choose to use nasal LAIV. The same survey also shows that only 9% of primary schools and 7% of secondary schools choose to use LAIV nasal spray. In 2022-23 season, the government procured 22,500 doses of nasal LAIV for the SIV programs, of which 17,400 doses were administered for students. The remaining unused vaccine of about 5,100 doses were disposed because they have been expired in March, because the validity period of nasal LAIV is rather short and we have to dispose of them in March. The wastage rate is about 22.7%, which is higher than the vaccine wastage of IIVs, which is 13.1%. For IIVs, that is the injectable inactivated influenza vaccines, IIV and nasal LAIV actually apply to different groups of people. As for the use of nasal LAIV, is limited to certain group of people, and the validity period is rather short. It will expire in March, and that also cannot apply to people with certain diseases, for example, those with asthma. So people should choose the kind of vaccines that are suitable to them. Taking the experience of COVID-19, the hospital authority adopted certain measures. For example, we adopted this phasic plan. That is a comprehensive phasic response plan. For high-risk elderly, we provided certain service to them, and also we provide ad hoc consultation support in the form of telehealth or face-to-face to RCHEs, and also we adopt this PPP program with private healthcare service to provide teleconsultation and medication delivery. We'll continue to look at the situation and implement appropriate measures, and we will arrange for the SIV programs in the next seasonal influenza season so that we can establish a protection network. If I may remind the public that they should receive a vaccination in October. Thank you, Secretary. If members would like to put questions, you can press the button now. I'll read out the names. Edward Leung, Chang Wing Kwan, Chan Kin Por, Tommy Chang, Chang Pui Leung, Yan Wing Kit, Judy Chan, David Lam, and myself. 4 minutes, please. Mr. Edward Leung. Thank you, Chair. There were people who say that we should increase the vaccination rate among children. That is, by incorporating IIVs into the SIVs and introduce nasal LAIVs among children. The Secretary said that this may not be the most appropriate measure. As for education, it takes time. So what measures do we have in order for us to increase further the vaccination rate? Because over the past 1 year, there were some children who passed away because they sustained influenza or suffer from influenza. Secretary, in terms of vaccination among children, is on a voluntary basis. Parents should be the one to make the decision, and we should educate them about the consequences of suffering from influenza. In this season, we have a number of chronic influenza complications among people, and 4 children actually passed away because they caught the seasonal influenza. After COVID, there were parents who were exhausted and have vaccination fatigue. I'll ask my colleague to talk about our outreach program. We actually have offered a number of options for our parents. I have to stress that vaccination is and should be done on a voluntary basis. Dr. Al. Thank you. Through different channels, we educate the members of the public, parents, and schools about the importance of vaccination. And when we notice serious cases of influenza, we announced those on the news and we issued press releases. School outreach program is a very effective way for us to increase the vaccination rate among children and young people. So 2 years ago, we started implementing the school outreach program at kindergartens and primary and secondary schools, and we regularized the pilot scheme. And in 2022-23, we started implementing the outreach program in secondary schools. This school outreach program actually increased the vaccination rate among young people substantially. We wrote to schools, and through Education Bureau, we issue letters to parent-teacher associations and other groups to encourage them to allow their children to receive vaccination. So through PPP and the school outreach program, we try to boost the vaccination rate, and we see that over the past 2 years, the rate has increased progressively. But there's still room for improvement for certain groups of people. So in terms of the options that we make available for schools, we try to improve those so that we can have our participation rate further boosted. We also work with different medical groups.
Next member, Professor Chen Wen-Kwong. Thank you, Madam Chair. Good morning, Secretary. The government adopts different measures in response to influenza, but for senior citizens and those below 12, the vaccination uptake is still on the low side, 51% and 64% respectively. Members of the public are not willing to take vaccines or vaccinate against their children because they are worried about any complications or side effects. So are you going to change your publicity measures, strategies, and will you enhance the safety of vaccines in order to allay the concerns of members of the public so that they will have peace of mind when they vaccinate? There is the SIV School Outreach Free of Charge program. Teams go to schools to vaccinate children. This is actually a good program, but October is said to be the best time to get vaccinated. Quite a lot of parents said that they had to wait until December before their children can be vaccinated with manpower. That's why parents are concerned. I'd like to know whether the administration will redeploy manpower resources in order to send officers to vaccinate children as early as possible in order to reduce the chances of infection. Secretary, we can see that members of the public are less worried about the safety of vaccines of influenza when comparing with COVID-19 vaccines. We will enhance our publicity on the importance of vaccination. In this season, we identified serious cases, and children are indeed a prime concern. We hope to mount more publicity programs to hammer home the message about the importance of vaccination. Regarding the vaccination uptake of senior citizens in Hong Kong, let us take a look from this perspective. The vaccination uptake in the RCHEs is more ideal. The figures is above 80%. For senior citizens such as singletons in the community or even those living with their family members, they may not have enough information about the importance of getting vaccinated. Regarding the vaccination school outreach program and timetable, there needs to be a timetable for us to make arrangements. I'd like to ask Dr. Albert Au to give you more information regarding school outreach program for children. He can give you more information. Dr. Au, please. Thank you. As the Secretary said just now, when we rolled out the school outreach program, which is usually at the start of October, when we receive the vaccines, we roll out the program immediately. In July and August every year, we hold introductory sessions to tell schools about the details and arrangements about the school outreach programs. In the sessions, we were told that the winter flu season may come in December, and it takes around 1 to 2 months before antibodies can develop in the bodies of children. We hope that this year we can work with schools in order to iron out their difficulties so that they can roll out the programs as early as possible. Next, Mr. Chen Kim-por. Thank you, Madam Chair. I'd like to refer to paragraph 9, a territory-wide sewage surveillance program. In the panel earlier on, that is in September, the Secretary mentioned that he would consider extending the program to cover seasonal influenza. I'd like to know the progress so far. Regarding the nasal LAIV, nasal spray is only applicable to children. It's not available for primary and secondary schools. They can only get vaccinated. So for those who are afraid of vaccination, they give up on getting vaccinated. Will you consider extending the services of nasal sprays to primary and secondary schools as well? In the community, it is also said that the efficacy of nasal sprays is different from vaccination. It is also said that nasal sprays are not available for people aged 50 or above. Is that the case? Secretary, In the COVID-19 pandemic, we saw that the sewage surveillance method was very useful. We collect data on a weekly basis. In the fourth quarter of this year, we will conduct a review. We will see how we can use sewage surveillance in infectious disease control. Regarding the outreach program, in kindergartens, primary and secondary schools, there are also outreach programs, but they are a little bit different. The CHP sends officers to schools, and we also want to make good use of PPP. We subsidize private doctors. They will go to school to vaccinate children. Per dose, the subsidy is $260. Some 45% of the doctors only receive the subsidy and did not receive the additional fee. So, to schools, to students, is actually free. Both primary and secondary schools can also choose this method. Besides, schools need to choose one type of vaccines. That is, they can choose traditional vaccination or nasal sprays. Kindergartens and primary schools also have outreach programs. Private doctors go to kindergartens and primary schools. However, in primary schools and in secondary schools, only 9% of primary schools and 7% of secondary schools choose nasal sprays. In the questionnaires, parents chose vaccinations instead of nasal sprays. The reason why we didn't offer both types of vaccines is that there is a clinical concern. The vaccines can be mixed up. When two vaccines are available in one single school, from the perspective of school arrangements or professional arrangements, there are difficulties. So we only allow one school to choose one type of vaccines. That is to ensure safety. Regarding nasal LAIV, it's different from injections. For those who are immunocompromised, the efficacy is not as great. I'd like to ask Dr. Bao to give you more information. Thank you, Secretary. This scientific committee discussed the efficacy of both vaccines. Experts had a consensus that both vaccines were equally effective, but their nature still differed, so the targets are still different. Nasal LAIV are not applicable to children aged 2 or below. It is only applicable to people aged 2 to 49. For those using aspirin, they cannot take the nasal sprays. For those who have had history of asthma or those between the age of 2 and 4, if they have history of wheezing, they cannot take nasal LAIV as well. Those who are pregnant couldn't receive nasal LAIV either. So it's all down to the decisions of members of the public. So you're not saying that all those above the age of 50 cannot receive the vaccines across the board, is that correct? Well, actually, this kind of vaccines is only applicable to those aged between 2 and 49, as those who are those senior citizens are afraid of vaccination as well. Well, that's actually based on scientific research. It's actually an inactivated influenza vaccines. Mr. Tommy Zhang, well, I'm not young, but I'm not afraid of getting vaccinated. I'm just worried that the nurses or doctors are not as skilled when they vaccinate me. $260 is quite expensive, But I don't quite understand why schools do not choose private doctors. For schools that are close to hospitals, can they send students to hospitals where they can receive vaccinations? You can make arrangements in relation to time. Is that possible? I'm not sure if you can do it. After all, you need to encourage the young and the old to get vaccinated, and this is good. Have you considered, for example, having lucky draws? For students who go to get vaccinated, you can prepare gifts or something that senior citizens like. You can have lucky draws. You don't need to spend a lot of money, but you can create an ambience in a community. Last year, or at the start of this year, I heard that more people came down with flu or cold. Some people in the industry told me that they had sourced the wrong type of vaccines. I mean, there was a mismatch. I'm not criticizing you. There's a report from the North America, the predominant strain of virus, and you procure vaccines accordingly. But then if afterwards you find that if the strains have mutated, do you have sufficient time for you to procure yet another type of vaccines for members of the public to get vaccinated? Or will you ask members of the public to get the second dose of vaccination? Will you do so? The Secretary. I'll take the second question. For the first question, that is the outreach program details, I will ask Dr. Abao to give you more information. That is for gifts for private doctors going to schools. Dr. Abao will give you more information. Regarding vaccines, the WHO announces information about the strain recommendations. That is the predominant strain in the Northern Hemisphere. They're based on scientific judgment as well as data. I need to emphasize, influenza vaccinations prevent serious cases or fatalities. For ordinary persons, I mean, when we look at data, for children cases or severe cases or even fatalities, they don't get vaccinated. For those who have been vaccinated, the likelihood of severe cases or fatalities is on the low side. That means vaccinations are effective in guarding against severe cases or fatalities. And time is not sufficient for us to source yet another type of vaccines. When announcements are made in February or March, we need to culture the relevant virus before we procure live attenuated influenza vaccines. It takes a long time. So it's simply impossible to procure vaccines targeting 2 to 3 different strains. And Dr. Abao?
Thank you, Mr. Cheng, for your suggestion. We'll think about that. For the school outreach program, we looked at evidence overseas which shows that school outreach is the best way for us to encourage vaccination among children. And for us to transport children elsewhere for vaccination, that will affect its effectiveness. As for child care centers and kindergartens, the vaccination rate is 80%, primary school 90%, and for secondary school it's 70%. We do see an increase over the years. For schools that opt out of the outreach program, we talk to them to see why they're not participating in it. And we will try to encourage them to take part in the outreach program. 62% of the schools said that they want to encourage parents to bring their children to subvented clinics for vaccination instead of their schools. And some schools told us that they don't have enough manpower and space. This accounts for 37%. And there are 23% of schools think that they have too many activities, and that is why they cannot arrange for vaccination sessions. And we will try to help these schools out. You can ask the colleagues from the Education Bureau to talk to the schools. Next, Mr. Champuilan. Thank you, Chairman. Paragraph 3 of the paper. The nasal LAIV. You conduct a study among primary and secondary schools on it before procurement. But after the survey, well, there's still the wastage rate of the vaccines are still very high. I wonder why that is. Will you make adjustment to enhance the accuracy of your study so that we have a lower vaccine wastage rate? That's my first question. Second, we do see a number of serious cases during the influenza season, and most of these patients are being hospitalized, and the hospital authority increased the number of beds to cater to these cases. It's easy for us to increase the number of beds, but I wonder if there is any issues with manpower, and will the hospital authority be redeploying their staff to cater to the demand, and will that pose further burden on the healthcare staff in the system? Secretary, prior to the influenza season, which is now, we start estimating the vaccination rate. Of course, we want more people to be vaccinated, but that's their own choice, especially with children. So we have to make an estimation before we procure the vaccines. And we have to strike a balance. If we procure and purchase too many vaccines, some of them will be wasted. If we procure too few vaccines, then some people may not be able to be vaccinated. We have to avoid these two scenarios, and that is why we have to come up with a estimation. We do have a mechanism with the pharmaceutical companies for us to procure additional vaccines. All countries and places around the world are trying to procure vaccines from pharmaceutical companies, and these companies have to set a level of manufacture. I will ask Dr. Ao to elaborate on the mechanism. Thank you. As the Secretary has said, when we estimate the volume of vaccine, we base that on our survey. We looked at our estimation and the actual figures. These two figures are actually not too far off, and the wastage rate is, in our opinion, low. As for nasal LAIV, the packaging of it will result in higher wastage because in each of the package it contains 10 nasal LAIV. When the box is opened, we have to use all of the sprays. The reason why the wastage rate is so high for LAIV nasal sprays is because we 1/4 of the childcare centers and kindergartens actually make use of nasal LAIVs, and some of these centers and kindergartens have very few students. If there are 31 students who want to receive vaccinations, we have to open 4 boxes of nasal LAIVs. What about manpower? I'll ask Dr. Tan to elaborate on that. Dr. Tan, please. In terms of increasing hospital beds, we have to increase also manpower. That is why we have special allowance for nurses and doctors and ICUs, pediatric department, and A&E department. And we also enhance public-private partnership. We have low-charge beds, and we work with private hospitals, and we refer suitable patients to private hospitals so that we can make available extra beds to cater to patients in need during seasonal influenza peak. Mr. Yamankit, I want to follow up also on the vaccine wastage rate. The administration said that they have balanced various factors before arriving at the figure of procurement. But the wastage rate of nasal LAIV is about 22.7%, which is higher than the 13.1% vaccine wastage of IIVs. Will you be adjusting the number of vaccines to be procured? Because if you perhaps lower the nasal LAIV volume by 10% and lower that for IVs by 5%, we can reduce the wastage rate. For vaccination rate among secondary and primary schools, they are not very high in terms of nasal LAIVs. If there is a wastage rate of 22.7% for nasal LAIVs, shouldn't we consider offering nasal LAIVs for free for students so that we can provide certain incentives for schools to choose nasal LAIVs instead of IIVs? The second point, how do we encourage the community to take part in the SIV program? Well, other than last year, actually my office has always taken part in the SIV program. It's very complicated for us to fill out the form to participate in the program because we have to spend a long time on it. Shouldn't the government simplify the forms so that more offices in the districts would participate? Care teams actually are also helping out their community. I think that the administration should strengthen their collaboration with the care teams to boost the vaccination rate, because only 70 to 90% of the schools are participating in the outreach program. Because when I organize the vaccination sessions at my district office, other than elderly persons, students also came to be vaccinated. So actually, the vaccination sessions organized by the district offices plug the loophole. Shouldn't the administration simplify the form to encourage people to participate? Secretary, in terms of wastage rate, it's 22.7% for nasal LAIV and 13.1% for IIVs. I'm talking about 2022-23. The influenza season for this year is not ended, but actually we offer 1 million free vaccines and the wastage rate is less than 4%, which shows that it's very difficult for us to estimate the demand. As mentioned, there is a 20% increase in terms of the doses of vaccines administered comparing with last year. This poses difficulties for our colleagues in estimating the number of vaccines to be procured, and there is certain uncertainty involved. If we want to achieve a 0% wastage rate, some people may not be able to be vaccinated. As for the forms, I will ask Dr. Ao to elaborate on that. As for subsidy, I'm grateful for the member for signing up or organizing the vaccination sessions at their district offices. We want to meet the demand of hidden cases. The vaccination rate of RCHEs is very high. I agree with you that we have to figure out these hidden cases so that elderly singletons will be vaccinated. Dr. Ngao, thank you for your suggestion. As for the outreach sessions to be organized by the community, they have to apply for it because we have to ensure the quality of the vaccination service. So we ask the relevant community groups to fill out certain forms. I will see if we can simplify the forms or streamline the procedures so that when community groups or LegCo members, district councillors organize these sessions, they will have their administration procedures streamlined. At the community level, we rely on district councillors, LegCo members, and care team to help us in promotion and encourage hidden cases to be vaccinated. We will work with the Home Affairs Department to see if we can leverage on care teams. I hope that the government will consider offering nasal LAIV for primary and secondary schools free of charge. Ms. Judy Chan. Thank you, Chair. I am concerned about the vaccination rate among primary and secondary school students. Some 70 to 80% of schools participate in the outreach program, but only 60% of people aged below 12 were vaccinated. 2 months ago, there were 4 children who passed away because of influenza. I think that the government should take a step forward. According to the paper, the government said that they asked the schools to choose the type of vaccines. I have a child at kindergarten and another at primary school. But I wonder if the administration only asked the schools. Me as a parent was never consulted on whether I want to have my children receive vaccinations in the form of nasal spray or injections. I spent a lot of effort persuading my children to be vaccinated. If we allow parents to choose the form of vaccines, then this will encourage them to allow their children to be vaccinated. I disagree with what the Secretary said. I don't think that there will be confusion if we allow the same school to choose both nasal LAIV and IIVs. The school can arrange a morning session for nasal LAIVs and an afternoon session for IIVs. We can have the schools organize the IIV sessions and arrange for a mobile booths outside the schools to administer nasal LAIVs. I don't think that would be as chaotic as the Secretary described, because this will actually alleviate the worry of the children and the parents, and this is very useful in boosting the vaccination rate. The Secretary said that the most ideal time to be vaccinated is October. The peak is at April and May, and parents, when they see serious and severe and fatal cases, they start having their children vaccinated by then, and that may be too late. after the school outreach program has passed, it's very difficult for me to arrange for vaccination for my children, and I have to go onto the website to see which doctors offer vaccination service. Is there a simpler ways for me to have my children vaccinated?
Secretary. Thank you, Madam Chair. Thank you, Ms. Judy Chan. Regarding the choice of different vaccines, without doubt, it's not me who decides on the type of vaccines, it's the school instead. We need to have schools to agree and to make arrangements. Some schools said that they did not have sufficient time or they didn't take part in our vaccination program. We need the collaboration of schools. That's their choice between studies and health. Of course, we do want to have all schools taking part in our vaccination program, but when it comes to the choice of schools, that's their professional choice, that's their administrative decision. From the perspective of medical officers, they think if schools have both types of vaccines, there may be room for mistakes. Some schools said that they couldn't find one single time slot, so they won't be willing to allow 2 time slots. Both schools and parents also need to understand the importance of vaccination against seasonal influenza. We'll step up publicity and we look forward to the fact that more schools and parents will be willing to join the vaccination program. Regarding vaccination, this year we have already administered over 1.85 million doses, which is more than the figure last year. At the peak of influenza, members of the public identified severe cases, so they were willing to get vaccinated despite the fact that they were not willing to do so at the start of the season. To private doctors, in the first few months, that is between October and February, fewer people would get vaccinated, and their stock of vaccines will also decrease. It's about vaccine wastage. In May or June, if doctors still have a lot of stock of vaccines, they will have to discard these vaccines. That's a problem we have every single year. So we need to vaccinate the public as early as possible, starting from October, so that we don't have to see these vaccines go to waste. Can I respond? I'd like to respond to the first reply given by the Secretary. If you present to the principals of schools the nasal LAIV, of course, they would not opt for it. You need to charge them. They have a shorter expiry period. Those with asthma cannot take the nasal sprays. There are simply too many obstacles. There are many limitations. As other parents or members said, if you want to protect children, you shouldn't charge either of the vaccines. I'd like the Secretary to set the record straight. It's just that when someone who has asthma affecting them, they cannot take the spray. It is not the case that all who have asthma history should not take the sprays. Regarding the vaccine wastage, is there any central platform to pull the resources together? For example, we can collect all the vaccines in mobile clinics so that parents can go to these mobile clinics in order to drive down the vaccine wastage rate. Secretary? Well, I have to clarify. Be it nasal LAIV or IIV, the charge is still the same. it is not the case that they need to pay extra for nasal LAIV. Regarding the validity period, it is shorter. They may expire after March. But this still does not affect the judgment or the decision of the schools at the start of the season. Schools can still choose nasal sprays. So from the perspective of the expiry period or cost, none of them shouldn't be any concern. These two types of vaccines are of different nature. On the consent forms, there are two consent forms. They are different. We cannot tell the parents these two types of vaccines are identical. After all, they need to sign the consent form with informed consent. For asthma, it's about the proposal by the scientific committee. It's based on clinical and scientific data. I'd like to ask Dr. Abel to give you more information. Thank you, Secretary. Thank you, Deputy Chair. For nasal LAIV, indeed, the scientific committee reviews and discusses the applicability of the vaccines. The scientific committee said those who have had asthma or those between the age of 2 and 4 who have had history of stridor in the past 12 months, they shouldn't get the nasal sprays. That is because the nasal sprays may induce asthma. When they have asthma onset, they shouldn't take the nasal sprays either. What about the centralized platform of the vaccines? Well, I'd like to talk about the informed consent. We understand some parents want to opt for nasal sprays, but as professional medical officers, we wouldn't administer the sprays just because they want to do so. We will definitely let parents know the contraindications. That's the rule that we must go by. We won't keep parents in the dark about the contraindications just because we want to boost the vaccine uptake. We have two types of two methods of vaccines, of providing vaccines. One, the government provides these vaccines. Two, private doctors procure vaccines from pharmaceutical companies. Private doctors decide on the quantity to be purchased. Pharmaceutical companies have sufficient supplies. We also remind these companies to have sufficient stock to provide to private doctors. Next, Dr. David Lam. Thank you, Madam Chair. Those working in the front line have been saying that the participation rate among schools has been changing. Parents, teachers, associations should give advice to schools. I mean, when they give advice to schools, that will also affect the vaccination uptake. When schools do not offer nasal sprays, students can still go to their family doctors. Vaccination uptake and medical needs are different. They may not feel that they need to get vaccinated. Will the administration consider relaxing further the vaccination of seasonal influenza? Will the administration consider vaccinated all members of the public against seasonal influenza? Regarding the purchase of vaccines, the Secretary mentioned two procurements, one by the government and two by private doctors. This year, from October to November, we ran out of vaccines. Companies said that they could only stock up on vaccines until November or December. Some doctors said probably we could ask the DOH to lend us some vaccines. And in December, a lot of members of the public said that we were already past the peak of the seasonal influenza period, so they wouldn't take the vaccines anymore. Therefore, a lot of vaccines have gone to waste. Will the administration adopt another method? For example, in the course of the COVID-19 pandemic, we had a centralized platform for procurement and vaccination. When we need vaccines, we can turn to the DOH, which can send the vaccines from a centralized platform. Then we don't have to worry about the amount to be procured or the fact that we may purchase too many vaccines. There are many respiratory infections. Not all of them are seasonal influenza. Some are COVID-19 cases. Some are other types of respiratory diseases. Will the administration issue clearer guidelines? That is, for people in different age brackets, what kind of vaccines should they receive? For example, COVID-19, RSV or RSP. RSV. Will the administration consider telling the public more through e-health? Thank you, Dr. David Lam. Regarding who should receive vaccines free of charge, it depends on who is in the high-risk group. All over the world, they conduct the same assessment. We act upon the advice of the relevant committee regarding vaccination. And we vaccinate the highest risk group according to the advice given by the relevant committee. Regarding the respiratory diseases, the scientific committee conducts meetings on a regular basis. The last time they had meeting was in March. In case of any change in the vaccination strategies, they give advice to the government, and we will announce the strategies or advice. In relation to procurement of vaccines, private doctors have their own decisions. Regarding whether we can have a centralized platform to centralize the stock of the vaccines, Dr. Abao can give you more information in a moment. The administration already told pharmaceutical companies that the vaccines that the administration had procured could be given to private doctors first, so that the private doctors will not run out of vaccines. Dr. Abao, in April, in May, we get in touch with private doctors and we tell them to procure vaccines and sufficient vaccine as early as possible. As the Secretary said, the WHO made suggestions every year in February and March. And they can order vaccines in May or June, so they can order sufficient vaccines as early as possible. That's what we remind doctors of. We also remain in close dialogue with the pharmaceutical companies. We have procured sufficient vaccines under the government vaccination program. We get in touch with pharmaceutical companies and we allow private doctors to get our procurement first. That is when the supply is tight. That's the mechanism we have in place right now. I have nothing to add. Thank you.
好，最後一位就係我。
It's my turn. First of all, I know that the government and the sector have been adopting different ways to boost the vaccination rate. But we have to look at the situation this year. We have a rather prolonged influenza season lasting from January to June. So I think that apart from reminding people to be vaccinated in October, I think that there is a certain discrepancy between HA and CHP. The CHP said that the influenza season is between March and April and July to August. We have to look at the serious and fatal cases from January to June. For the 4 children who passed away, 3 were aged between 6 to 11. For people aged between 12 and 18, the vaccination rate is double that of last year. But for children aged between 12 months and 6 years, in 2018 and 19, the vaccination rate was about 40 to 60%, and this is still the case today. There is no substantial increase. For serious and fatal cases, they happen to children of this age group, that is, children between 12 months and 6 years old. Do we have any targeted measures to boost the vaccination rate for this group of children? Why is there no significant increase over the past few years? I have a suggestion. District councillors and LegCo members organize vaccination sessions at their district offices. The reason why it's so popular is because parents don't want to go to the hospitals or clinics to have their children vaccinated. They don't want to have their children come in contact with other patients. And because usually these district offices are located within the residential developments, the reason why the school outreach program is not popular is because I want to be the role model for my children, and I want to be vaccinated together with my children and perhaps domestic helper. We cannot do this at schools. So apart from asking why the school does not participate in the program, the administration should learn why the parents don't want to have their children vaccinated. For government vaccination program, only people aged above 50 and those aged between 6 and 18 years old can receive vaccination for free. I think that it's okay to have wastage because I want the government to procure more. But in 2022-23, 1.85 million doses were procured. There is a wastage of 22%. It means that 180,000 doses were being disposed of. Why can't we have parents, children, grandparents, domestic helper be vaccinated together? If we can allow that to happen, the wastage rate would be lower. Second, on promotion and publicity. The topic today is a prevention of seasonal influenza. There are different ways to do that. Children, when they are sick, they wear face masks. We have a prolonged influenza season, lasts from January to June. Schools no longer ask their students to take their temperature before they go to school, and their sanitizers are often out of stock. So I think that we have to not just ask children to be vaccinated, we should adopt also other measures to fight against influenza. Thank you. Secretary. Let me first answer a question on people who are not our target group and how we can lower the wastage rate. Well, we have to decide on the target groups prior to procurement, because if we want to target more people, we have to increase the volume of vaccines to be procured. If we increase or expand the target group, then the wastage rate would be higher. So what you said actually didn't make sense. We rely on the scientific company and WHO, and we, as well as countries all around the world, establish the target groups for free vaccination. For the publicity at schools, I will ask Dr. L to elaborate on that. Thank you. Agree with what Ms. Chan said. We have to boost the vaccination rate among the community, and we cannot rely on school outreach program alone. We have to step up publicity on various fronts. We actually asked parents why they didn't have their children vaccinated. Some parents are hesitated because they were worried about the side effects, and they think that their children would have their immune system improved after suffering from seasonal influenza. We will step up publicity to clear all these understanding. We need to have the assistance from schools, private medical doctors, as well as Education Bureau for us to bring the right message to parents. As for infection control, we update our guidelines every year, and we will step up publicity, especially at universities. Prior to the start of the season, we write to schools to ask the schools to implement preventive measures, for example, asking the students to take temperature before going to schools. Secretary, I want to supplement. There is expiry date to the vaccines. 3 months prior to the expiry of vaccines, if you have some tens of thousands of vaccines, then you should let parents know. Parents are actually willing to pay to have their children to be vaccinated, but all they want is to be vaccinated together with their children, parents, or domestic helpers. You should let people know that you have a lot of vaccines left. We have a prolonged influenza season this year lasting from January to June, and if you say that's still effective for people to be vaccinated now, then they would come to have their children and themselves vaccinated. That's my suggestion. Now we move on to the next item. Sorry, Ms. Chen Ka-pui, Judy Chan. Can I speak for the second round? Sorry. We have a lot of items to be discussed today. We have to move on. Next, outcome of the public consultation on tobacco control strategies and way forward. Would the relevant government officials please enter the room? Government officials, whenever you're ready. Thank you, Chair, members. Last Thursday, on the 6th of June, the Health Bureau, together with the C and ED, as well as the Hospital Authority, organized a press conference announcing our 10 measures to minimize the impact of tobacco on our community and safeguard the health of our people. The purpose of coming to this meeting today is to report to members on our strategies and the results of the public consultation, as well as the thematic household survey on smoking pattern in 2023 and outline the government's next phase tobacco control measures. We will talk about the 10 tobacco control measures as well as their operation. They are set out in the paper already. Smoking is harmful. We all know and recognize this piece of fact. 1 out of 2 smokers die prematurely because of smoking. 6 out of 8 fatal cause is related or are related to smoking and tobacco. Every year, according to the statistics, the economic loss because of smoking amount to about $180 million. The government all along adopt a step-by-step approach. We leverage on enforcement, education, taxation, smoking cessation, and legislation to strengthen and advance tobacco control. The smoking prevalence in the 80s was 23% after 40 years of effort. According to the Thematic Household Survey, it shows that the latest smoking prevalence in 2023 reduced to 9.1%. The result of the survey show that there are still 580 daily smokers so we have to step up our tobacco control measures. In terms of age group, the highest smoking prevalence to be found is in the 40 to 49 years old, which account to about 50% of our daily smoking population. If they continue to smoke, they will be suffering from chronic illnesses, cardiovascular diseases, cancers, and that will pose burden on our medical healthcare system. The male daily smoking rate has dropped to 16.4%. As for the female daily smoking rate, it has not been lowered over the years. Third, to cover the side effects of tobacco, the tobacco companies introduced flavors into their cigarettes to reduce their awareness of the hazards of tobacco. They want to encourage non-smokers that are teenagers to start smoking, to make it even more difficult for them to get rid of the habit. According to our survey, most of the young people, especially female people, they smoke flavored cigarettes when they first smoked. In the age group of 20 to 29, over 70% of smokers currently smoke flavored cigarettes. There are 580,000 daily smokers. Non-smokers, the entire society have to burden and shoulder the heavy price for the smoking-induced diseases, and this is a public health issue. Therefore, we have to implement various strategies to combat the smoking hazard. Hopefully, by 2025, we can reduce the smoking prevalence to 7.8%. To further safeguard public health, on the 12th June 2023 to 13th of September 2023, the government conducted the Vibrant, Healthy, and Tobacco-Free Hong Kong public consultation. During the 2-month-odd consultation period, the government received 10,000 online questionnaires and 12,000 online questionnaires. And we also conducted telephone survey as well as focus groups discussion to learn more about people's comments to make sure that the data that we collect is objective and also to enhance the representativeness and recognition of our data. We are glad to learn that over 90% of the respondents support reducing the smoking prevalence in Hong Kong. Most of the tobacco control strategies are supported by the majority of the public. After balancing certain factors, including the comment received via the survey, as well as the results of the thematic household survey, as well as the effectiveness of the tobacco control strategies, the operation of the strategies, and other factors, we formulated short, medium, and long-term tobacco control strategies. We have 10 short-term measures. On regulate supply and suppress demand, we have 5 strategies, including introducing a duty stamp system and raising the penalties for duty not paid cigarettes, prohibit the possession of alternative smoking products, prohibit provision of tobacco products to persons aged below 18 and review the effectiveness of increasing tobacco duty and the pace of future adjustments. In terms of ban promotion, reduce attractions, we will be banning flavored cigarettes, implement plain packaging. In terms of expand no smoking areas mitigate harm, we propose that smoking should be prohibited while queuing, and we also extend the statutory non-smoking area to designated areas, entrances and exits of designated premises, and also we will raise the penalty to $3,000.
方面，我哋
Next, on enhancing education and supporting cessation, we strengthen smoking cessation services as well as publicity and education. We will review the effectiveness of the measures in order to map out our future directions, that is, the medium-term and long-term measures. We have short-term, mid-term, and long-term measures. That's a pragmatic and progressive approach. We want to drive down the smoking prevalence rate. Our purpose is to build a smoke-free city, that is a tobacco-free Hong Kong. We'll ensure these measures can be implemented. We also hope the public will support us so that we can develop Hong Kong into a more vibrant and tobacco-free Hong Kong. We have with us the DOH and the CNED who will answer members' questions. Thank you, Secretary. Those who would like to ask questions, please press the request to speak button. Mr. Peter Shield, Professor Chen Wing-Kong, Mr. Tommy Chung, Edward Leung, Stanley Lee, Kitson Young, Ms. Dory Lee, Mr. Chen Pui Leung, Ms. Connie Lam. Mr. Peter Shield, please. On these 10 short-term measures, I don't agree with all of them. And of course, on enhancing education and supporting cessation, I support it. On expanding non-smoking areas and mitigating harm, as well as extending statutory no-smoking areas to residential care homes, for example, I agree as well. I also agree with increasing the fixed penalty for doing a smoking act in statutory NSA to $3,000. We need to respect those who smoke as well. People aged below 18 are not allowed to buy tobacco products. For those who provide tobacco products to persons aged below 18, they will be held criminally liable. I agree. From existing $1 million fine to 2-year imprisonment on summary conviction to $2 million fine and 7-year imprisonment on indictment, I support it as well. I agree with the major direction of implementing a duty stamp system. The government cannot solve cheap whites. The price of the cheap whites is still cheaper than the duty per se. With a QR code, then law enforcement officers can take enforcement actions accordingly. I believe this will be helpful, but this is only applicable to the packaging. There are only 2 places around the world that have QR codes on the cigarettes, and they are actually not really a QR code. They remind members of the public about the consequences or hazards of smoking. On prohibiting the possession of ASPs, that is alternative smoking products, the selling of ASPs has been outlawed. I flew back to Hong Kong twice, and I heard the announcements when ASPs are outlawed in Hong Kong. Passengers were agitated. Hong Kong is a tourism hub. The administration should think it through. Some people may have stocked up on heat-not-burn tobacco products, so how will the administration deal with the situation? You should maintain a close dialogue with these people. Actually, heat-not-burn tobacco products are very common around the world. I don't understand why people in Hong Kong couldn't choose this product. %40 of the smokers in Hong Kong are smoking flavored cigarettes. Actually, many people around the world also smoke flavored cigarettes. I hope the administration will consider whether there is any economic loss to Hong Kong. For the package warning on the cigar is very expensive. There are many counterfeit brands as well. If there is no security features, what about this? The administration should think carefully. Tobacco duty has been raised twice. The administration needs to strike a balance between public health and the liberty of the public. We need to look at a wider picture. We need to take a macro perspective. We need to draw reference from other jurisdictions as well. If our policies and measures are taken to extremes, will other tourists still come to Hong Kong? If so, no matter how much we work on tourism, the appeal of Hong Kong will still be undermined. From April 2022, heat-not-burn tobacco products cannot be imported into Hong Kong. Just now, Mr. Peter Shield mentioned the possession of ASPs is not allowed. That actually makes no difference. When they possess ASPs in Hong Kong, they need to import ASPs into Hong Kong. So in this case, they would have breached the regulation we imposed 2 years earlier. So that makes no difference. For those who still possess ASPs in Hong Kong, I believe they are from the stock that they have stocked up on earlier. It's not that they sourced these ASPs illegally. There's a buffer period. In this period, they can surrender their ASPs and the equipment. We'll have a reasonable buffer period for members of the public to use all these products, or they can surrender these products. Regarding heat-not-burn cigarettes, in the THS, flavor cigarettes are very serious. Their hazardous consequences are actually identical comparing with those of traditional cigarettes. The flavor simply is added in order to cover the odor of traditional cigarettes, but then the hazards are identical, in fact. The additives or flavor of shisha or water pipe is the same. I hope members of the public will consider more seriously. You need to consider it more carefully. That's actually a promotional ploy. When members of the public don't understand the consequences or hazards of flavored cigarettes, they will be affected. I will ask Dr. Feng, the head of TACO, to give you more information. Most mainland tourists who come to Hong Kong are non-smokers. Non-smokers always outnumber smokers. When they come to Hong Kong, they don't come to Hong Kong just to smoke. They come to Hong Kong to identify business opportunities. They want to experience our culinary experiences, tourism experiences, and so on. So when we have a tobacco-free, vibrant, and healthy Hong Kong, it's always better to have a city that is full of smoke. In Little Red Book or in WeChat, we can see that there is much support for the tobacco control measures in Hong Kong. They even want these measures to be implemented in their own area. Dr. Feng, regarding the impact on flavored cigarettes, the European Union, comprising 27 member states, Canada, and the UK, they have also banned flavored cigarettes. Some studies have shown the effect on the ban. In Canada, there are more people who try to quit smoking. That is for those who are traditional smokers of rolled cigarettes. Some teenagers use fewer tobacco products. In the UK and the European Union, after the ban of menthol cigarettes, the use of menthol cigarettes or flavored cigarettes is actually cut by half. Studies show that with flavored cigarettes, smokers will be more willing to try cigarettes. It will be more difficult for them to quit smoking. After the ban on menthol cigarettes, the situation has improved. For flavored cigarettes, the officials cited examples from the EU and the UK. In Asia, our situation is different. Well, I mean, some tourists do not come to Hong Kong anymore. These tobacco products are all the rage in Asia, so I believe it has much of an impact on Hong Kong. Well, no tourists actually come to Hong Kong just for smoking. You just cannot describe the situation this way. Next, Professor Chen. Personally, I support the tobacco control measures of the administration, but I think that they should be implemented in a targeted manner. Some tobacco control measures come with a lot of difficulties. For example, prohibiting provision of tobacco products to persons aged below 18. These can protect minors. This can prevent them from getting in touch with tobacco products. It is a good one, but there is many difficulties in relation to evidential burden. The extended statutory NSAs are also a good idea, but it's difficult for law enforcement officers to take actions on the spot. Well, do we have sufficient manpower resources? Like you said, Secretary, we need to stare at these people when they smoke. Will you add more resources to make sure that these measures are implemented in a targeted manner? Among the many tobacco control measures, we need to take measures. We need to take enforcement actions. But we also need to foster a culture in the community. In NSAs, that is no smoking areas, from the 80s, when we started to have indoor no smoking areas, we only banned smoking on escalators, elevators, the lower deck of double-deckers and then extended to public areas, workplaces, eateries, for example, we met with much resistance from the outset. Without doubt, I can put it bluntly, TACO simply cannot send officers to every single indoor space. It may take a very short period of time for someone to smoke. NSAs have become a culture in Hong Kong. All members of the public are also part of TACO. We are repulsed by smoking. Actually, smokers are under stress when they smoke in indoor areas. NSAs have been extended to queues. We understand that it's simply impossible to send TACO officers to all bus stops or public transport interchange. TACO's work is complicated. They don't simply wait for smokers and take enforcement actions. They need to step up publicity, they need to promote tobacco control measures, and so on. We will add more manpower. But I believe we need to foster a culture, we need to create an ambience in the community. You mentioned law enforcement work is quite difficult to prohibit provision of tobacco products to persons aged below 18. For example, for child abuse cases, how can we take enforcement actions? How can we conduct investigation? We are facing the same situation, but when some minors are in possession of tobacco products, we will carry out investigation accordingly. Thank you, Professor Chen.
You.
Mr. Tommy Chang. Thank you, Chair. Secretary, I think it's useless for me to talk to you about these points, but I still have to say them. When we banned smoking in workplace in 2005 and 2006, the LegCo visited a number of places, including Norway, Ireland, and Thailand. The government officials at those countries told us that if there are 16% of smokers in the country, then we don't have to work on smoking prevalence anymore. Singapore had a smoking prevalence of 14%. They were better than us. Today, the smoking prevalence is some 9%. The government is still working on a tobacco-free Hong Kong. I think that the administration should dedicate the resources to other areas. I have to declare interest. I am a chronic smoker. So I think that you're listening to me with a tainted glasses, with a pair of tainted glasses. Salt is also a hazard to people's health. Shouldn't we ban salt as well? You said that you will ban smoking while walking, and you will also prohibit smoking while queuing. Do we really have to go this far? You don't have to answer my question. I will leave some time for other members to put their questions. You must understand this. We have this issue with democracy. This word emerged some thousands of years ago. The reason why democracy cannot be implemented effectively is because there is this concept of tyranny of the majority. It seems that because the majority of the people are non-smokers, you're trying to deprive the small number of smokers' rights to smoke. And this is why democracy cannot be implemented successfully. You always talk about the majority. Let's look at the survey that you've conducted. You said that 91 people supported you, and 91% of the people support your effort. But then those 91% of people are non-smokers. Of course, they would support your effort. Usually, when only 30 to 40% of people support your measures, you should ask why those remaining people don't support you. You shouldn't go too far. Otherwise, things could go wrong. I think that everyone is concerned about their own health. You don't have to really dedicate so much resources on this subject. And I think that you should focus your resources and money on educating the teenagers so that they don't start smoking in the first place. And we should tell them about the hazards and impacts of smoking instead of putting an ugly woman on the package of cigarettes. Secretary, before you respond to this question put by a heavy smoker, I want to ask members this because we are at 12:21 p.m. We're supposed to end the topic at this point, and we should start discussing healthcare manpower projection. But as we all know, we've spent much time on discussing the seasonal influenza and tobacco control strategies. There are 7 members who would like to put questions, excluding myself and Deputy Chair. We can only wrap up this topic by 1 p.m. and we have a House committee coming up in the afternoon. What should we do? There is no urgency to the healthcare manpower projection, Mr. Peter Xu. I think that we should postpone the healthcare manpower projection to the next meeting, and I think that the Health Bureau shouldn't put 3 items within the same meeting. The Health Bureau should allow time for electoral members to discuss. Well, I have actually relayed a relevant concern to the Health Bureau because seasonal influenza and tobacco controls are very important. If we all agree, then we should postpone the discussion of healthcare manpower projection to the next meeting, and we will end the discussion of the tobacco control strategies at 1 p.m. There are other government officials at the waiting room waiting to come in. We should notify them of our decision. Secretary, I want to, Mr. Tommy Chia is leaving. I'm trying to answer his question, so perhaps I shouldn't continue with my answer. Secretary, perhaps the media also wants to know about your answer. I know that Mr. Tommy Cheng would use up all his time to give his comments instead of putting questions to us. The smoking prevalence of other countries is high, and that is why their target of 16% is satisfactory. But actually, that is just a interim prevalence target. When the countries recognize the hazards of smoking, they will further try to lower their smoking prevalence. Smoking is harmful to our health. We always want to improve our own health, and that is why we will not be stopping at this smoking prevalence of 9.1%. In the interest of time, I will not be addressing other parts of Mr. Cheng's comment, but I have to stress that the results that we have achieved in terms of improvement of people's health is very substantial. The economic loss because of smoking amount to $1.8 trillion, and Hong Kong also sustained a loss of $8 billion because of smoking. If you don't control the smoking prevalence, we will waste a lot of resources in terms of healthcare. Mr. Albert Leung. Tobacco control is a good thing, but are we going too far? The government tried to increase duty on alcohol, gambling, cigars, private cars, in order to discourage people from engaging in such activities or purchasing such products. The government is trying to ban activities that they don't encourage. What impact does it bring? We have to think about that. We try to create a diverse and accepting community. If we are just banning the smoking, are we will the government try to ban cigars, alcohol, private cars in the future? Shouldn't we just impose a special duty on activities and products that we don't encourage? That's my first question. Second, is good for us to try to catch up with Singapore, US, and UK, but is this a good thing for us to become the first in the world? But are we drawing ourselves off the cliff by implementing such a pilot program to lower the smoking prevalence to 0%? Will our image and reputation be undermined by banning tobacco altogether? Secretary. We're not the only city adopting such strategies. These strategies are actually adopted by other countries and places. These are the strategies set out in the paper are not all the measures that we have. We have considered the feasibility, the acceptability of these measures, and we separate our strategy into short, medium, and long-term measures. For people smoking while walking, a lot of people support banning such an activity, but we see difficulties in terms of operation and enforcement. Disputes could arise. That is why, after much thought, we categorize such a measure in the long-term strategy. As for prohibition of smoking while queuing and extending the NSAs to entrances and exits of designated premises, these measures are adopted in other places. And in some other places, they designate a large NSAs. I don't think that we have gone too far, and I think that the measures that we adopt are appropriate. Excuse me, I'd like to follow up. Shouldn't we replace banning by special duty? You said that we're not going too far, but banning all these methanol-flavored cigarettes, water pipes, this will not be beneficial to our economy. Shouldn't we impose a duty so that we provide more options for our people? Bhutan has a similar smoking prevalence, but the size of our economy is 185 times of theirs. Secretary. Duty of cigarettes and tobacco is the most effective measure to lower smoking prevalence. Well, I talked about methanol, fruit-flavored cigarettes, and water pipes. Shouldn't we discourage people from using these products by imposing duty instead of banning them? Secretary, we will try to see how we can better control heated cigarettes. Under the thematic household survey, we see that flavored cigarettes are very enticing to teenagers. tobacco companies try to adopt different tactics to lure teenagers into smoking flavored cigarettes. And teenagers often think that flavored cigarettes are not as harmful.
You.
Next, Mr. Stanley Lee. Thank you, Madam Chair. I support different tobacco control measures, but what to control, when to control, what is the effect? We need to discuss all these. We need to strike a balance when it comes to tobacco control measures. There are many illicit cigarettes, and the situation is dire in Hong Kong. It shows that when cigarettes are more expensive, even when members of the public understand the hazards of smoking, these citizens still turn to illicit cigarettes instead of quitting smoking. I believe the administration should respect the choice of members of the public. If smoking does not impact on others, that is non-smokers, should smokers be given more freedom? I agree with tobacco control measures when smoking affects non-smokers, but I do think that we need to strike a balance. I agree that the statutory non-smoking areas should be extended and how to combat on smoking while walking. I believe if the administration is determined to do so, they will succeed. But will heated tobacco products or menthol cigarettes be banned? This will only drive smokers to the flavored cigarettes, and the black market will also be made more buoyant. The administration said that they could take it further, but there's much backlash in the community. I understand the administration wants to protect the health of the public, but cigarettes are not drugs. Unless you ban all cigarettes across the board like drugs, then I have nothing further to say. But some members of the public will still smoke no matter what you do, no matter what you say. They think that smoking is like spiritual help to them. So how can you strike a balance? I hope the administration will consider further. For smokers who have been smoking for a long time, indeed, they have difficulty quitting smoking. This is understandable. That's exactly because tobacco products contain nicotine. And nicotine makes tobacco products addictive. Among the 10 tobacco control measures, our ultimate goal is to help 580,000 smokers to quit smoking. We want to give them an incentive. Quitting smoking is good. From the THS, we can see from the figures that more and more teenagers smoke flavored cigarettes. In addition to helping 580,000 smokers to quit smoking, what is more important is that we need to prevent teenagers from smoking their first ever cigarettes. So these 10 tobacco control measures should give incentive to smokers to quit smoking. But on the other hand, we also want to prevent non-smokers, especially teenagers, to not take the first smoke. Mr. Kisan Yang. Thank you, Madam Chair. I support tobacco control measures. I agree with increasing the tobacco duty rate. I also agree with extending the statutory no smoking areas. These are good measures. After all, smoking and alcohol is harmful to health. We all understand that. But we should also give people a right to choose. Smoking is harmful to health, but so is alcohol. It should also be banned. But some people choose to smoke but not drink. But there are also people who choose to drink but not smoke. All these are down to the personal choice of different people. I agree that it's important to prevent teenagers from taking the first smoke. That is very important. The 10th point is to enhance education and support cessation, but I believe more should be done on education. You need to let teenagers understand the hazards of smoking so that they won't take the first cigarette, and that's on the front burner on the tobacco control measures. But the paper doesn't mention these a lot. Will you discuss with the Education Bureau on implementation among the many tobacco control measures? For example, e-cigarettes cannot be imported into Hong Kong, and in Hong Kong you can smoke while waiting in line. So how can you promote all these to tourists? It's important to hammer home this message to tourists. In my own office, I also received some cases where they sought help. They brought an excessive amount of cigarettes into Hong Kong and they were fined. This reflected a problem. Why didn't they know these policies of Hong Kong when they arrived in Hong Kong? We need to do more. We need to do more on publicity, or else visitors will find it inconvenient, or trouble will be caused to tourists. In border control point BCP, they buy cigarettes. But what about duty not pay cigarettes bought in BCPs? Some cigarettes are bought in other countries. We allow tourists to bring 19 cigarettes into Hong Kong. That is 19 sticks of cigarettes into Hong Kong. When there is no stem, can you prosecute these smokers? Can you say that, well, actually these cigarettes are cheap whites? Can you do so? Secretary, I'd like to mention publicity first. How should we let tourists know our strategies? Actually, whenever we go to other places to travel, we check the customs requirements. Let's not talk about just ASPs. Let's talk about cash. Many countries around the world have requirements in relation to the amount of cash you can bring in. Visitors do have the awareness to check. Let's not talk about sticks of cigarettes. Let's talk about fruits, cash, and so on and so forth. Of course, we'll step up publicity. When there are any changes in the importation requirements, we will step up publicity. On publicity efforts to visitors or in schools, I will ask Dr. Feng to give you more information about publicity. In relation to stamps, we'll start a consultancy investigation. We'll draw reference from other countries, including the requirement of a maximum of 19 sticks of cigarettes. We'll look into the situation and we'll see how we can implement the measure. Dr. Feng, in relation to publicity at schools, there are many projects rolled out by COSH. The DOH also sponsors NGOs to implement teaching and learning activities in relation to the hazards of smoking. We get in touch with over 10,000 students every year. We can see that our education activities have come to fruition. Smoking prevalence at schools has been on the decline. Mr. Kitson Yang. Well, on the duty stamp system, Why don't we first study the implementation details before we roll out these policies? Otherwise, we are like putting the cart before the horse. That will be problematic. Well, I'm afraid you have got us wrong. We don't implement before we legislate. We have already started our consultancy study. We hope that the results will be available in 3 months. If you find that the policy cannot be implemented, will you still carry on with the policy? Well, we'll have to see the findings or the outcomes of the consultancy study. These measures have been put in place in other countries, but the consultancy study is all about the implementation details. Dr. Sari Lee. I recognize the tobacco control measures. Ever since I joined the Legislative Council, the secretaries of previous terms have been doctors. As a district directly elected member, many supporters are actually smokers. Many smokers are against increase in tobacco duty rate. They are adults. When you allow them to buy cigarettes and when you keep increasing the tobacco duty rate, they are against it. But then the backlash in the community has been reduced. I believe they have already found their own way to solve the problem or to get around the problem. Increasing efforts to put in place tobacco control measures, this is definitely right. The WHO has a target to reduce smoking prevalence so that our world will become a tobacco-free world. So should we ban the sale of tobacco products outright? When we allow the sale of cigarettes, but we are still putting in place many tobacco control measures. This is self-contradictory to me. I believe there are many different factors at play. So when we consider different measures every year, there's bound to be many opposing views. If there are indeed many negative consequences or hazards of smoking, should we still allow the sale of products? As I said at the beginning of my comments, I recognize the efforts of the Secretary. In particular, I support the fact that we should prevent teenagers from taking the first smoke. The minority should obey the majority. And the prime principle right now is to develop the economy. We want to attract tourists or visitors from all around the world so that Hong Kong can stay vibrant. We can continue to enjoy the principle of one country, two systems. We need to recognize talents in the mainlands are smokers. It's actually their habits, and this may drive them away. Correct me if I'm wrong. The policies in New York, in London are not as strict. So comparing with other international financial centers, will our status be affected? At this point in time, our status is very important to Hong Kong. And there are different views in the community. I hope that the administration will take on board different views, different suggestions in the community. I understand that some measures may be contradictory at times, so we need to think which target is the most important, and I hope the Secretary will give it some thought. Thank you.
Secretary, Let me explain about the WHO target and their proposals. We know that there are different countries in the world and they have different smoking prevalence. Some countries have a 50% of smoking prevalence because they have a very strong smoking culture in their countries. The target of WHO is never 0% in terms of smoking prevalence. The reason why we want to achieve the smoking prevalence of 7.8% by 2025 is because of this proposal made by WHO using 2010 as the baseline and base figure. The WHO wants all countries in the world to reduce their smoking prevalence by 30%, regardless of the prevailing smoking prevalence at that time. The WHO target is to reduce smoking prevalence by 15% in 30% by 15 years time. And that is why we have this target of 7.8%. And in 2018, we established this goal and we accepted the WHO's recommendations. What do we mean by tobacco-free Hong Kong? Of course, we know that there will be people who break the law and try to smoke. We take 5% as our standard. I will ask Ms. Dr. Fong to elaborate on it. She will talk about the tobacco control measures recommended by WHO. In a lot of places, in terms of economic activities and traveling activities, well, Singapore and such places have tobacco policies that are even stricter than ours. We may not be able to replicate what they're doing, but we perhaps should make reference from their practice. When foreign tourists come to Hong Kong, for talents who come, I think that they come for the cuisine, for the business opportunities that we have to offer, as well as our cultural experience that they can enjoy. So I don't think that our tobacco control strategies would affect that. I will ask Dr. Fong to talk about the WHO tobacco control measures. As mentioned by Secretary, the WHO never said that we should reduce smoking prevalence to 0%. They have an Empower package. We should start from education, and we should impose a heavier duty, and we should take enforcement action to reduce smoking prevalence. So for the strategies that we have in the paper, including extending the NSAs, banning flavored cigarettes, imposing a duty stamp systems, all these strategies are within the tobacco control framework as recommended by WHO. We just follow their recommendations. Mr. Chan Pui Lan. Thank you. I completely support the tobacco control strategies that the government have. But there are certain measures that may be difficult to be enforced. For example, prohibiting smoking while queuing and extending the non-smoking areas to the entrances and exits. Is it really possible for us to define what kind of activities would constitute violation of the laws? And if there is something that is not clear, a lot of people will be caught by the law inadvertently. Second, how do we create this tobacco-free culture? I think that if we can do it and create such a culture, we will be able to control tobacco. If people feel guilty about smoking, then they perhaps would stop doing so. And that actually helps with our enforcement action. We cannot just rely on the staff of the TACO. it's better for us to create a tobacco-free culture. And when people see others smoke, they would ask them to stop. Also, we should leverage on technology. I know that the police have installed a lot of CCTVs over the territory. Perhaps we can make use of the footage and treat it as a form of evidence to enhance enforcement action. Second, on smoking cessation services, do we have any such service that target long-time and chronic smokers, smokers that just picked up smoking? Do we have any targeted smoking cessation services? And I wonder how many people have quitted smoking after receiving smoking cessation services, and I wonder how effective these services are. Secretary, I would like to thank Mr. Chen for his support to our strategies. In terms of expansion of NSAs, we cannot rely on enforcement action alone, but by taking enforcement action, we want to create a culture and let people know that it's illegal to smoke in NSAs. This is like how we take enforcement action against jaywalking. We don't place enforcement officer in each and every pedestrian crossing. But as long as we have created such a culture, and when children know that we're not supposed to cross the road during red light, then they would ask their parents not to do so. And I think that we have achieved such results in indoor area. We all know that it's not okay to smoke in indoor areas. As for whether we will make use of cameras to take enforcement action and regarding the smoking cessation services, I will ask Dr. Au to elaborate on that. Thank you. In terms of enforcement, we have to identify the smoker. We ask the smokers who have violated the law to produce their proof of identity. In order for us to take enforcement action, we will look into whether we can use technology to facilitate that. In terms of smoking cessation services, it is very well-rounded. The service providers cover HA, DHC, and non-government organizations and cessation clinics. As for whether we have targeted measures for different target groups, we have a treatment model. We provide acupuncture, we provide treatment services, and education. The medical staff will look at how addicted the smoker is and what challenges they are faced with before they offer counseling service to help these relevant smokers, and before they prescribe the drugs. In terms of smoking cessation services, the cessation rate is about 20 to 60%, depending on where these smokers are recruited from. I will first extend the meeting by 15 minutes because it was supposed to end at 1 p.m. Ms. Lam So-wai. Thank you, Chair. I support the tobacco control strategies, but I think that some of them may be difficult to enforce and some of them are controversial. For example, the introduction of a duty stamp system. If we are to stamp each and every stick isn't it difficult to enforce? Will the government examine each and every stick? Now, we are only allowed to import 19 sticks of cigarettes to Hong Kong. For foreign tourists and mainland visitors, they have to purchase cigarettes within their territory. Now we're banning methanol, fruit-flavored cigarettes. Are we also banning visitors from bringing flavored cigarettes into Hong Kong when they come? I wonder if we will ban people smoking while walking, because when they smoke and walk, that affects a lot of people. However, I think it's difficult for us to define smoking while walking. I think that there are other simple ways for us to cope with the problem. Take Japan as an example. They have a smoking area within their metro stations. For some states in U.S., they don't allow smoking at covered and indoor areas. I think that would be easier to understand so that they know where they can or cannot smoke. Secretary. Thank you. Regarding duty stamp tips system, we will put a stamp on duty-paid cigarettes. So when we identify cigarettes without such a stamp, it means that it's not a duty not paid cigarettes. It's easier for us to take enforcement action, and by having this system, both buyers and sellers would know if the cigarettes have had the duty paid. In terms of the operational details, as I've mentioned, we will start a consultancy study to see and look into the operational details, because such a system has already been implemented in other countries and places. We will make reference to their regulations and practices. In terms of flavored cigarettes, are we banning the sale and purchase? We will decide on that when we legislate. As for smoking while walking, should we ban it? As you can see in the THS, most people actually support banning smoking while walking, because people walking behind the smokers have no way to escape from the secondhand smoke. I know that it's difficult for us to enforce it. As for designated smoking areas in places, but we don't want to create this impression that we are creating areas for people just to smoke. And I think that this is counterproductive, and we don't want to send the wrong message that we are allowing people to smoke in certain areas. We will continue to look into it, but our strategy now is to expand the NSA instead of creating smoking area. Secretary, there are a lot of smokers who smoke around the litter bins. I don't think those places are legal smoking areas. You said that 90% the respondents of the survey composed of 90% of non-smokers and only 10% of smokers. But there are people who need to smoke because of psychological reasons. Shouldn't we designate a small room in the transport interchange, for example, to allow people to smoke, because we are humans after all? Not all people can quit smoking after you ban tobacco. We don't ban smoking outdoor. We are just expanding the NSAs. Most of the outdoor areas are not no smoking areas. So it's not illegal for us or for people to smoke around the litter bins. Those are not no smoking areas. When we are coming up with, as for our tobacco control strategies, we're just extending the NSAs to designated areas as entrances and exits of designated premises.
Yeah.
Next, Mr. Michael Tin. Secretary, I've been listening to you for a long time. I may be the only one that is on the same wavelength with you. In 2007, 50% on the smoking of the cigarette packages have images and the health warning, as well as the smoking cessation hotlines. Well, now that smoking has a lot of harmful effects, contains some 70 carcinogens and 7,000 chemical substances, why can cigarettes still be sold? The administration has not answered this or explained this. The administration is not taking any drastic steps. So, why isn't the administration banning the sale of cigarettes across the board? Some say that the economic development and the tourism sector will be affected. However, when Hong Kong has become a tobacco-free city, probably more people will come to Hong Kong, since non-smokers outnumber smokers. Let's turn to human rights. On hobbies, on health, many medications can only be prescribed by doctors. Well, there are always medications that can cure depression, autism, and so on. So doctors can be the gatekeepers. On hobbies, all of us have hobbies. Is it impossible for us to sacrifice our hobbies? Why can cigarettes be sold, but we can't smoke cigarettes? Well, probably you can ban the sale of cigarettes outright. I'm all for your measures. Let's assume in 2025 the smoking prevalence is reduced to 7.8%. The WHO said that every 15 years, smoking prevalence should be reduced by 30%. By 3%. By 30%. In 2030, new diesel vehicles will be banned. The sale of cigarettes will also be banned. These will be shocking milestones, so to speak. Well, the WHO said that when we reach 5%, we can call ourselves a tobacco-free city. It's actually not impossible to reduce the smoking prevalence from 7.8% to 5% in 10 years. So when we reach 5 years, we can call ourselves a tobacco-free city. You can expect that there will always be smokers who smoke without being discovered. So probably in the future, smokers can only smoke in the country parks. I'm not sure. So my question is, 10 years later, any indicator? Will Hong Kong become a tobacco-free city? Next, on the definition of A tobacco-free city, can you tell us more about it? Thank you, Mr. Michael Tin. We see eye to eye with each other. You really know me. And I believe many people in Hong Kong actually support our work on tobacco control. A tobacco-free city will attract more visitors to Hong Kong, as non-smokers are actually the overwhelming majority. A lot of people hate being forced to smoke secondhand smoke. They can really see the repercussions of smoking. Actually, for nicotine replacement therapy, NRT, they are incorporated into our tobacco control measures. Smokers will have an easier time quitting smoking. There are 200 or so points for smokers to get NRT. There are also community pharmacies which distribute these kits without the prescription of doctors. We even have services such as mail to quit services. They can receive cessation medications by post for free. For smokers who are affected by nicotine, we hope they will be incentivized to quit smoking. Our smoking prevalence stands at 7.8%. The figure of 5% is proposed by some countries to call oneself a tobacco-free city. 0% is not possible. It's a utopia. So can we ban cigarettes as if cigarettes were something illegal? Well, actually, cigarettes have been in our society for a long time. So in our deliberation, we have been thinking that we should adopt a multi-pronged approach and a progressive approach. We'll continue with our direction, that is to reduce smoking prevalence. So with your definition being 5%, do you think we can reach our goal in 10 years' time or 10 years later? So do we need to ban the sale of cigarettes across the board if we are to achieve the smoking prevalence of 5% 10 years later? We'll review our short-term measures. As I mentioned, we have short, medium, and long-term measures. We hope to roll out all short-term measures within this legislative year. In 2026, we'll review the effect of the short-term measures. Then we'll explore medium-term measures. We want to achieve tobacco endgame. That is, in the future, people under a certain age cannot buy tobacco products. The sale will be prohibited. I can tell for sure we can remain our low smoking prevalence, but at the same time, we can continue to reduce smoking prevalence with our tobacco control measures. Dr. David Lam. Thank you, Madam Chair. I understand that economic development is close to the hearts of many members. But let us first assume that it is substantiated. When we can attract visitors to come to Hong Kong, but then we have a lot of more smokers, we have an aging population, there's a swelling population of smokers. There are also many smoking-induced diseases such as lung cancer, as well as other diseases like cardiovascular diseases. So it seems that it won't drive economic development. What we're worried about the most is that teenagers are lured by flavored cigarettes. Probably they are non-smokers, but they are enticed to give the first try. We had menthol cigarettes long ago, but fruit-flavored cigarettes only emerged recently. They didn't exist long ago. And actually, tobacco companies used fruit-flavored cigarettes to entice teenagers to smoke the first cigarette. Is actually not a choice for these teenagers. You simply conceal the hazards. You keep them from seeing the hazards, actually. Any response from the Secretary? Well, thank you, Dr. David Lam. The administration has short, medium, and long-term measures, and many short-term measures cover or involve some legislation work. So I'd like to know the manpower resources. I understand the manpower in TACO is quite limited. You have a lot of measures, but will you increase the manpower of TACO? Let's not talk about additional legislation. In case of any non-compliance of smoking, you encourage members of the public to make a report or complaint to TACO. But when I click onto the complaint page, TACO only operates between 9 a.m. and 1 p.m. and from 2 p.m. to 5:30 p.m. On weekends, it's not open, and the hotline is actually diverted to 1823. Some smokers actually smoke in the back alley. Eatery operators are probably in a catch-22. On the one hand, they do want to have law enforcement officers to arrive. So how will you increase the manpower of TACO? We have CNED with us. I'm not talking about illicit cigarettes. I mean cheap whites. There are many cheap whites in newspaper kiosks in the community. So why don't you combat cheap whites? It's actually easy to mount decoy operations. What is the reason for not taking legal action? Some ethnic minority schools or teachers have sought assistance. They said that it is difficult to purchase other kinds of tobacco products. The products that they can chew. I first of all exercise my power to extend the meeting for the administration to take my question. Yes, I was asking about chewing tobacco. And a response from the CNED. We'll stick to the established mechanism to request additional manpower. On the law enforcement work in NSA, the working hours of TACO, as Ms. Rebecca Chen mentioned, is between 9 a.m. to 5:30 p.m. on weekdays. However, we do have weekends, public holiday, and nighttime law enforcement work. For example, last night we had a special operation. We mounted decoy operation in bars. We issued penalty tickets. Regarding law enforcement work in NSA, we have been reviewing our work in order to enhance our efficiency. We send plainclothes officers to take legal enforcement actions. So the tickets issued have increased by 60% in 2023 comparing with the number in 2022. In eateries, in the back alley, the effectiveness has become greater. Will the manpower be added with more measures? Well, we need to really take stock of the situation after the rollout of the measures. And then with the existing mechanism of the government, we will request additional manpower. Thank you. The CNED, regarding operation of cheap whites, we have been enhancing our operation. We issued press releases to keep the public up to speed. From storage, reseller, and the sale of these cigarettes, we have been mounting operations. We will collect intelligence, and if need be, we will mount large-scale operation. And we will also keep a close eye on cheap whites in Hong Kong. What about chewing tobacco or smokeless tobacco products? In Hong Kong, all these are banned in Hong Kong. They cannot be imported, nor can they be sold. But they are banned and regulated from the perspective of food. They are regulated in accordance with food-related regulations, while comparatively they are cheaper, and there are many ethnic minorities in Hong Kong. These students in ethnic minority schools affect one another. So you're going to ramp up your efforts targeting traditional cigarettes. So can you also ramp up the enforcement efforts in relation to smokeless or chewing tobacco products? Well, we can discuss with the relevant units or departments, but they have already been banned as a type of food. No other members would like to speak. This is the end of this agenda item. The last agenda item, AOB, any other business? Any AOB? No, meeting adjourned. Thank you, members, and thank you, the administration.